My presentation is on resistant hypertension. Juliet, Catherine, kindly allow me to share. Host disabled participant screen sharing. I'm unable to share my screen. My talk today is on resistant hypertension, where I will review the diagnosis and management of resistant hypertension. So the outline of the talk really is to look at the definitions, the diagnosis of treatment-resistant hypertension, a little mention on the causes of resistant hypertension, but the gist of the talk will be to review some of the society guidelines on the evaluation and management of these patients. Now, I want to clarify that this talk is not on resistant hypertension among either CKD or dialysis patients. Later on, we will have a session that will cover hypertension in dialysis, because we know that is a totally different scenario. Some of the recommendations and guidelines that we'll discuss here may not actually apply in our late stage CKD patients and patients on dialysis. It's a whole different playing ground. Nonetheless, even as nephrologists, we are physicians first, and we are often faced with this patient who has a difficult to treat hypertension. You're not reaching goals, but the patient does not actually have CKD, or if they do, it is the early stages of CKD. So I think it is important for us to review this topic. So I have borrowed quite a lot from these two papers. The 2018 scientific statement from the American Heart Association on detection, evaluation, and management of resistant hypertension. I've also borrowed quite a bit from the 2017 American College of Cardiology, American Heart Association guidelines on the diagnosis and management of high blood pressure in adults. So I will hereof be mentioning them as either reference 1 or reference 2. So just as a form of introduction, we know that hypertension is the world's leading risk for cardiovascular disease, include also for stroke, cause of disabilities, and also cause of death. Interestingly, even with the improvement over the last 30 years in awareness, treatment, controls, still we have a large proportion of hypertensive adults who fail to achieve their blood pressure targets, even with multiple medications. Now, I want to go through, speaking of targets and thresholds for diagnosis and management of hypertension. This is an area which has evolved quite a bit over time, and these targets keep changing. Earlier on, almost 2 decades ago, we had the JNC7 in 2003, which basically gave us the thresholds of in non-diabetic, non-CKD patients, thresholds of 140 systolic and 90 diastolic, and in diabetic patients and CKD patients, cutoffs of 130/80. Now, around 2014, the 8th Joint Commission on the Diagnosis and Treatment of Hypertension actually went up with the thresholds for people less than less than 60 years old. They set the threshold of 140/90, and for those people who are older than 60 years, the thresholds went up to 150/90. This was based on, among other data, some 2 studies which were done in Japan, which did not show benefit when an ambitious target blood pressure of less than 130/90 was compared with milder ones of goals of 150/90. But this didn't last long, these guidelines, because there was a lot of controversy. People were concerned as how is it that we have these high treatment thresholds in people who are at increased risk of cardiovascular events, that is the older patients. And a lot of people thought that this may be suboptimal treatment for this population. And after the studies that were used to guide these recommendations were reviewed, these recommendations were basically, it was agreed that they need to be reviewed. In 2017, the American Heart Association, American College of Cardiology revised the guidelines and went quite much lower on the thresholds and blood pressure targets. And this was basically guided by emerging data, which showed benefits of intensive lowering of blood pressures. And one of these papers was the SPRINT trial. This was a randomized multi-center double-blind controlled trial that wanted to compare the safety and efficacy of intensive blood pressure lowering to less than 120 compared to the routine management of less than 140. And interestingly, the study population included people, hypertensive patients with at least one more cardiovascular risk, including elderly patients above 65. Some actually were above 75. But the intervention was actually stopped early because there was a significantly lower rate of primary composite outcomes of a myocardial infarction, cardiovascular disease, and all-cause mortality in the intensive group compared to the standard group. And you can review this paper. This guided the 2017 guidelines from the American Cardiac College of Cardiology and American Heart Association. Included here was also several other societies, the European Society of Cardiology, among others. And you can see that after in the 2017 guidelines, the targets and cutoffs for diagnosis and treatment goals went quite low. Hypertension was reclassified to be that a diagnosis of hypertension would be a diastolic of 130, above 130 and above 80. And anything above 140 over 90 would be basically stage 2 hypertension. And you can see the cutoffs, the treatment goals went down for almost all the categories of patients, except for those who had a much lower cardiovascular risk, 10-year cardiovascular risk. But for the majority of other patients, the treatment targets and cutoffs for diagnosis went down to 130 over 80. Now, you would have thought we'll stop there, but sometime this year, another society called the International Society of Hypertension came up with some guidelines. This was published in June this year. And their focus was actually on the use of ambulatory blood pressure monitoring and home blood pressure monitoring or measurements as compared to the office blood pressure measurements. So they gave us these guidelines or these thresholds and treatment targets that for office blood pressures, we go back to having a diagnosis, making a diagnosis of hypertension when the systolic blood pressure is above 140 and the diastolic is above 90. Then they give us a guide for the ambulatory blood pressure monitoring and home BP monitoring, where for 24-hour average of ambulatory BP monitoring, the thresholds were now 130 over 80, for daytime 135 over 85, and for nighttime 120 over 70. But for office BPs, we went back to the JNC 7 guidelines of more than 140 over 90. This keeps evolving, so we'll probably get more clarification on this, depending on the patient's comorbidities, compelling indications, whether that should change these cutoffs. Nonetheless, what we are seeing is that as these guidelines, as the cutoffs get lower, it will mean that we will have more patients who meet the criteria for a diagnosis of resistant hypertension. I put up these terminologies here because we're going to define them and because they need to be differentiated from a true resistant hypertension. So according to the American Heart Association 2018 scientific statement, resistant hypertension was defined as a blood pressure that remains above goal in spite of the concurrent use of 3 antihypertensive agents of different classes. Now, the caveat here was that one of these agents should be a diuretic, and 2, these agents should be prescribed at optimum dose, where optimum dose is defined not necessarily as the maximum manufacturer's recommended dose, but the maximum tolerated dose by the patient. And these agents should also be given at the correct dosing frequency. Now, patients who have a hypertension which is controlled with 4 antihypertensive medications also fall in this category of a resistant hypertension. But the other caveat to the diagnosis of resistant hypertension is that we have to ensure accurate BP measurements, and we have to ensure that the patients have adherence to their prescribed medications. Otherwise, you will be talking about pseudo-resistant hypertension as part of the resistant hypertension. You'll be talking of white coat hypertension as part of the resistant hypertension. So this needs to be ruled out before we make that diagnosis of resistant hypertension. This is really just what we have said in a more pictorial form, where we're saying that for you to make a diagnosis of resistant hypertension, the patient needs to be compliant to their medication, and you need to measure the blood pressures accurately. Now, so you'll define this as if you have accomplished this and the blood pressures are still above target, the patient is on 3 medications, where 1 is a diuretic, and these medications are being given at optimum dosage, then you can confidently make the diagnosis of resistant hypertension. This is really a pictorial just to emphasize on the correct and accurate measurements of blood pressures. We probably overlook some of these aspects. Quiet room, patients should at least be relaxed. Then the other issue is the issue of the cuff size, that the cuff size needs to cover at least 75 to 100% of the individual's arm circumference, and that the arm needs to be at the level, rested at the level of the heart. So again, we need to be just a reminder that inaccurate blood pressure measurements can actually lead you to making a diagnosis of resistant hypertension when actually you do not have resistant hypertension. Now, the other thing is that these patients who have resistant hypertension are actually at a high risk of vascular events than those who have a controlled hypertension. They also tend to have this more probability of them having a secondary cause of hypertension. So we need to sort that out. There's this other terminology of refractory hypertension which seems to be coming up. And these two, they were actually single center studies, but they defined the term refractory hypertension to that category of patients whose BPs are above goal using 5 different classes of antihypertensive agents. And this should include a long-acting thiazide diuretic and a spironolactone. So if a patient is on all these medications and their BPs still are above goal, then this is a patient who has a refractory hypertension. And once again, it has been shown to have more poor outcomes than compared to just plain resistant hypertension. So it would appear the more medications that you need to control your blood pressures, that again increases your cardiovascular risk. The term pseudohypertension basically just means that this is not true resistant hypertension. It means that there is the patient's blood pressures are not controlled because either they are not taking their medication, because of the white coat effect or because of inaccurate blood pressure measurements. We also see it, it is also, the term is also used to, applies to elderly patients who tend to have thickened calcified arteries, which may require much higher cuff pressures to occlude. And you end up reading this as a higher blood pressure than it actually is. Now, you can suspect a pseudo-resistant hypertension, or rather, resistant hypertension, which is not truly resistant. In some of these situations where you have this patient whose blood pressures are high, over time, but they don't seem to be developing any features of organ damage despite these elevated blood pressures. The other situations where you'd suspect pseudo-resistant hypertension is these patients who, when you increase their medications, they become hypotensive, or when you increase the dose, they become hypotensive. Then it would mean probably this patient was not taking the medications they were, which you assumed was not bringing their blood pressures down. And you can also confirm the diagnosis with imaging, where you may see calcification of the arteries in elderly patients. Now, what about the white coat effect? We know that this basically means that blood pressures are elevated when they're taken by a clinician in the office, but they tend to be much lower when they're taken outside the office. And this phenomena is thought to be, because of some alerting reflex triggered by the healthcare provider or the clinic environment that activates the sympathetic nervous system. And it tends to be more in people who are already diagnosed with hypertension and older individuals. But data has shown that the risk of the cardiovascular complications in patients with a white coat effect is basically similar to the risk of hypertensive patients who have controlled BPs. So yes, the risk does not go down to a patient who is not hypertensive, but it does not seem to confer extra risk. And again, this is the white coat effect can easily be identified by doing the 24-hour ambulatory BP monitoring or the home measured BP monitors. At the moment, they are also in the market. I don't think if they're available in our country. Some automated office BP oscillometric digital devices. They can record a number of BPs without necessarily the clinician being in the room. I haven't seen one actually. So, but I think this might be something that is new in the market to try and take care of this issue of white coat effect, which kind of makes your decision making when you're managing these patients a little difficult. So what is the prevalence of resistance hypertension? It has been shown to be about 13% among patients who are being treated for hypertension. Tends to be associated with older age, a black race, left ventricular hypertrophy, chronic kidney disease, and other comorbidities like obesity and diabetes. You find that patients with resistance hypertension are more likely to have these other comorbidities compared to people who have controlled hypertension. They also tend to have a higher risk of adverse cardiovascular events, like mentioned earlier, and more likely to have a secondary cause. Now, but what has been shown is that the prevalence of resistant hypertension among treated patients with hypertension differs quite markedly depending on the population where the data has been generated from. And what we see is that it is highest in clinical trials and much lower when we're talking about patients who are in the general population with hypertension. And this here is just a table. The table emphasizes on that aspect, that when you look at the population-based studies like the NHANES studies, the prevalence of a resistant hypertension among the patients who are being treated for hypertension was actually much, much lower. when you look at the clinic-based, when you look at the data from clinic-based clinical trials or cohort studies, what you find is that the prevalence of resistant hypertension goes a little higher. This was quite interesting that the ERICA study, which included quite a number of patients with CKD, had the highest prevalence of resistant hypertension. Now, when you go to the clinical trials, they accomplished, the prevalence of resistant hypertension in these clinical trials was quite high, going up to 30s and 40% of the treated hypertensive patients. Again, coming back to this, that the prevalence is a little difficult. Difficult to put a number on it because it really depends on the scenario where the data is generated from. Nonetheless, you can see that it is actually quite high if you're going up to 30-40% among patients who are being treated for hypertension. Now, what actually has been thought to cause resistant hypertension? You cannot ignore the aspect of the pseudo-resistant hypertension, which is, like we said, basically because of non-adherence to medication, physicians under-treating the patients, the white coat effect, and inaccurate blood pressure measurements. But then you have the true resistant hypertension, where you have basically addressed all these effects, but your blood pressure still remains above goal. So some of the causes of the true resistant hypertension that we need to look out for when you're managing these patients is to look for unrecognized secondary causes of hypertension. Because unrecognized, because if you make the diagnosis, some of these are actually reversible on treatment. You need to take the patient's medical history, medication history, find out whether they're taking concurrently taking medications that may raise or affect blood pressures. You need to assess this patient's salt intake and alcohol consumption, because those have been shown to actually contribute to elevated blood pressures, making those blood pressures quite difficult to manage. The other aspect that I wanted to highlight here was the issue of unrecognized volume or rather extracellular volume expansion. Saying unrecognized because if the patient had edema, then you would know that this patient has volume expansion. But that's sometimes these patients have volume expansion that is not much to be seen as edema. So it is one of the things that has been shown to contribute to resistant hypertension among these patients. And we will see more of that as we go along. Now, talking of the pseudo-resistant hypertension, this is an extract from this analysis which showed the prevalence of the various causes of pseudo-resistant hypertension among hypertension-treated patients. And you can see actually the physician aspect really comes in, the under-treatment, where the patient is on lower medications, on lower dosages than they really should be according to their blood pressure classification or severity. The other issue that contributes quite a bit is again, medication unadherence. There are previous studies, the days of all heart and accomplished studies. It was actually shown that up to 40% of our patients within 1 year, up to 40% of those patients do not take their medication, regularly, or some of them have actually stopped. So medication adherence is quite a challenge when you're dealing with a chronic, which is often asymptomatic. The patients, they require quite a lot of education. You can see my internet is unstable, so I might have to stop my video. Okay, we're back. So medication unadherence really contributes to these patients having a poorly controlled blood pressures. And then, of course, our blood pressure measurements and the white coat effect. Now, secondary hypertension, like we said, now when you have these patients who have true treatment-resistant hypertension, you need to look out for the secondary causes of hypertension, because they have, if you address the secondary cause, then chances are that you will be able to control their blood pressures. And in this analysis again, among patients with a true resistant hypertension, obstructive sleep apnea contributed really highly to as a cause of the or contributing to the treatment-resistant hypertension. Primary aldosteronism, renal artery stenosis, renal parenchymal disease, and drug-induced or rather concurrently taking medications that increase blood pressures, and heavy alcohol use also contributed to this. Also, thyroid disorders, both hyperthyroidism and hypothyroidism. And so this need to be diagnosed. You need to have a high index of suspicion when you have this patient whose blood pressures remained poorly controlled, and look for these secondary causes. And they have their diagnostic, not so difficult diagnostic tests to interpret and make the diagnosis. And most of them you'll see that actually do have some specific management. So it is important for us to look for these secondary causes of hypertension. Other causes that sometimes we may not, or we may forget to, consider is like exogenous glucocorticoid administration. Apparently, use of licorice has also been shown to somehow affect blood pressures. You have inherited disorders like the ENaC activation in Liddle syndrome, patients with metabolic syndrome, acromegaly, and like we said, including hyperparathyroidism. So if you've looked for the more common causes of secondary hypertension, they are all negative, yet your patient still remains poorly controlled, then you might want to think of looking for these more rare conditions which may contribute to poor blood pressure control. Having mentioned medications, these are some of the commonly used medications that make may make blood pressure difficult to control. The use of non-steroidal anti-inflammatory medications, use of oral contraceptives, use of sympathomimetics, and use of some of the immunosuppressants that we use, excessive use of alcohol and of vitamins, and all this somehow may interfere with the sympathetic system. So when you look at all these secondary causes, you ask yourself how they actually contribute to, elevating or an elevation to a blood pressure. And, this is not a pathophysiology class. So just in summary, it has been shown that some of the mechanisms that these secondary causes contribute to elevating blood pressures is increased vascular tone. Some of them may cause sodium and water retention, or an abnormal activation of the sympathetic nervous system, or abnormal activation of the renin-angiotensin-aldosterone system. So there is actually, the mechanisms have been identified how these factors may contribute to blood pressure, poor blood or elevation in blood pressures. Genetics and hypertension. Hypertension has a genetic basis. There is some heritability in our family-based studies, and it's shown that up to 50% of blood pressure variability can be attributed to some of these genetic defects. Some of these genetic abnormalities have been identified. I didn't want to dig deep into that because overall, there are very limited studies of the heritability of resistant hypertension, or actually the blood pressure response to specific blood pressure medications in patients with these genetic abnormalities. But it is though that there is some heritability of hypertension. Now, with that, we go to the evaluation of these patients. Again, quoting from this 2018 scientific statement from the American Heart Association. When these patients with a resistant hypertension come to you, the first step, of course, is to confirm that they do actually have true resistant hypertension. Is their blood pressure above goal? Are they on taking more than 3 antihypertensive agents? Do these hypertensive agents include a long-acting calcium channel blocker, or plus a blocker of the renin-angiotensin aldosterone system, and a diuretic? And are these at optimal dosages? This recommendation, I guess, was based on the reason that the first line is thought to be calcium channel blockers and either ACE inhibitors or ARBs. I think this is what has been accepted since the very large accomplished trial that compared the combination of calcium channel blockers with and ACE inhibitors with combination with a thiazide diuretic. So that has been actually the first line, unless the patient has compelling indications to want to use a different medication. Now, the next step, of course, again, ensure that this is actually true resistant hypertension by ruling out the causes of pseudo-resistance. And one of the ways you can confirm adherence is actually, in some of these patients, stop the medication and restart and see if the blood pressures actually respond. The other way you can try to confirm adherence, practically in practice is you may want to give these medications under direct observation as you monitor the blood pressures. The white coat effect, really the only way to rule out the white coat effect is to use home blood pressure monitoring or the ambulatory BP monitoring. Once you have confirmed true resistant hypertension, of course, again, assess for your secondary causes, assess for target organ damage, and address those issues. Now, when it comes to treatment, once you have confirmed true resistant hypertension and you have excluded the other causes of pseudo-resistance, then it is important for you to emphasize on lifestyle interventions. That is issues to do with weight loss, physical activity, sodium restriction, low sodium diets, and optimizing what the patient is already on, the initial 3 drugs, including a diuretic. If you have done this and the patient's blood pressures are still not at target, then according to the American Heart Association scientific statement on resistant hypertension, the next step is usually advised that you add the long-acting thiazide diuretic or thiazide type diuretic, which is clothalidone and indapamide are the ones which are recommended. And you will add these thiazide diuretics in that patient who has a GFR of more than 30. Because if a patient has a GFR of less than 30, the thiazide diuretics tend to be much less effective. And for that particular patient, it is recommended that you add a loop diuretic. The selection of changing the diuretic you're using to either specifically clothalidone or indapamide was actually advised by a number of studies. It's quite a number of studies which have compared the use of clothalidone with the most widespread thiazide diuretic has been hydrochlorothiazide. But studies have shown superiority in terms of efficacy, blood pressure control, when you compare clothalidone to hydrochlorothiazide. And some of the papers also have shown that indapamide is much more effective compared to hydrochlorothiazide. So really the first step for this patient is to change their diuretic to one of these and start small doses, escalate to the maximum tolerated dose. Now, you've done that and your patient still blood pressures are above goal. So the step 3, which has been advised, is to add spironolactone or the eplerenone, the mineralocorticoid receptor antagonists. Again, there's a caveat there that You probably want to be careful for patients who have a GFR of less than 30. There were some older guidelines which had given us some cutoffs when you're using serum potassium to make this decision, that if a patient has a serum potassium of less than 4.5, then you can go ahead and use your spironolactone. But if the patient has serum potassium of more than 4.5, then you're probably better off adding on a loop diuretic onto your clothalidone or indapamide. And this step 3 was guided on quite a number of trials, the largest of them being the aspirant trial and pathway 2 trial. The pathway 2 trial was actually one of the most give us most reliable data. This was a double-blind, randomized double-blind study comparing spironolactone with either placebo, doxazosine, or bisoprolol in 285 patients who had resistant hypertension. And this was defined as a mean clinic BP of 157/90 and home BP of 148/84 while they were on the calcium channel blocker, ARB, and a diuretic. And the results were that spironolactone significantly reduced the mean systolic blood pressures and compared to either placebo, doxazosine, or bisoprolol as an addition to the patient's backbone antihypertensive regimen. The superiority of spironolactone, not just in this study, has actually been shown to go over and beyond the levels of plasma renin or aldosterone. The benefits have been shown even in patients who have normal renin or aldosterone. The other one was the aspirant trial. Once again, it was an addition of a low dose of spironolactone to patients with a resistant hypertension. And once again, similar results were additional benefit in lowering their blood pressures. So it is advisable that you add spironolactone unless there's a contraindication. And you're adding spironolactone is actually now you are on 3 medications. You added the thiazide, now you're on the 5th drug actually. Now, if after your regimen of 5 drugs, this patient is still having blood pressures which are not on target, then it would seem that we don't have much clinical trial data to guide us in that. And this scientific paper of 2018, the American Heart Association, were very clear that the rest of the recommendations from here on are actually guided by expert opinion. So it is recommended that you add on drug if the patient does not have bradycardia, the patient's heart rate is more than 70, then you can add a beta blocker, either the selective or the non-selective, or you can add a central acting agonist such as clonidine or guanfacine. And if this cannot be used or not tolerated, then you can use the non-dihydropyridine calcium channel blocker, diltiazem. So now, the other caveat to the addition of the beta blockers and heart rate is that you have to be really careful about that patient who is bradycardic, because you want to avoid the beta blockers, you want to avoid the clonidine, you want to avoid the non-dihydropyridine calcium channel blockers. So you're probably better off adding the alpha adrenergic receptor blockers. But if the patient has a heart rate of above 80, then you're free to choose from either one of these medications. We also put a caveat about using beta blockers together with the non-dihydropyridine calcium channel blockers because of their tendency to cause bradycardia when used together. If at that point now you're at 6-7 drugs, you're still not controlled, the blood pressure is not controlled. At this point, you could add your vasodilators like hydralazine, start small dose and build up. And if the patient still has high blood pressures, then you can substitute hydralazine with minoxidil. Minoxidil seems to be, from my little experience, seems to be a tricky drug to use. Tolerability, the nausea, the vomiting, the dizziness tends to be quite challenging. So you can start with, it's recommended that you start with a small dose and you build it up to what the patient can tolerate. But this is really expert opinion. Our level of evidence ended with the step 3, really. Now,
and you wind
the
up.
other thing, okay, I'm actually done. The other things that you probably need to look at is if you still volume control, you can't get volume control with the thiazide, you can add on a loop diuretic, and you can patient heart rate is not controlled, then again you can look at these medications which can control blood pressures. Patients are renin levels and aldosterone levels may also guide you to either choose a mineralocorticoid receptor antagonist versus epithelial sodium channel blockers like amiloride. This is a concept where when you're monitoring home blood pressure measurements or the ambulatory blood pressure measurements, you can look at the patient's blood pressure pattern and sometimes change your dosages according to when they have the highest blood pressures, including splitting even those medications that are once daily into twice daily. Just some of the hacks that have been recommended or have been tried and shown to work. Now, what about that patient who fails at the end of all this? So the concept of sympathectomy has been there for a long time, from the 1940s. Like this paper was published in 1949 about lumbar sympathectomy in control of resistant hypertension. But it was accompanied with so many side effects that this is a procedure that was abandoned in the 70s. But it gave rise to basis for research for other devices which can be used in this. So what has been tried is a renal artery denervation. And initially in small studies, it had shown so much hope. But this was refuted in this Simplicity Hypertension 3 study, where renal artery denervation was not shown to be superior to sham procedures and medical therapy after 6 months. But there are new studies in the horizon showing promising results. This was the Simplicity study. You can have a look at it. The other interventions which have been tried are baroreceptor activation, but again was accompanied with facial nerve injuries. So it's still out there. There's a creation of a central iliac arteriovenous anastomosis. Once again, showed some promise, but still out there. So the conclusion is device therapy as of now is still investigational, and patients can only be applied in clinical trials. So in summary, resistant hypertension is common, portrays a worse prognosis compared to patients whose blood pressures are controlled. The prevalence is high, and as we keep shifting our blood pressure goals and targets, it is likely to go even higher. And the treatment is centered around maximization of lifestyle interventions, cessation of contributing factors, treatment of underlying secondary causes, addition of thiazide like diuretics, clothalidone and indapamide, a mineralocorticoid. And if BP still remains high, then the way forward is a stepwise addition of other agents with complementary mechanisms of action. Start low and build up, because with all these medications, the side effects are sometimes quite challenging. If a patient still has difficult to control blood pressures or blood pressures above goal, then you may want to refer this patient to a hypertension specialist, or they can take it from there and perhaps refer this patient for some of the device-based clinical trials. Thank you.
Okay, thank you very much, Dr. Wangari and Dr. Ndege. I think the presentation was very good and very concise, and this description of the stepwise addition of antihypertensive was quite clear. But if there are if there is any questions, you may go to the question and answer, and I will ask Dr. Muturi to kindly answer some of those questions directly from the chat in the event that there is any questions to be that is some clarification that somebody would like to have. I think unless there's any burning question, maybe you can take one or two. Otherwise, we would like to go to the next presenter, who is Professor Joshua Kaima, who's going to talk about the role of ambulatory blood pressure monitoring in CKD patients. Perhaps a combination of the two presentation may give rise to questions. If there are none, there is one question. How do we manage intradialytic hypertension to a patient whose adherence to his medication? I think the answer to this should be coming in another session. I think the fourth session from now. There's a special session on hypertension and dialysis. So I think you could wait for that session. Unless Dr. Wangari, do you want to answer that? The intradialytic hypertension. You want to say anything?
I think that will come very clear from our last presentation of this track 3. It's our last talk for this session.
Okay.
And yes.
Okay, so hold on, hang on. It will be comprehensively discussed in a session, 2 sessions from now. So thank you very much, Dr. Ndege, and for a very nice presentation, very comprehensive and easy to understand. Ease of understanding and ease of communication is always a factor in presentations. I think yours was very easy to understand, and we can cut and paste it and go and put it on our walls so that we can remind ourselves. Thank you very much.